Human respiratory syncytial virus infection, epidemiology, pathology, treatment, and prevention. Pause each illustration for a detailed study of the illustrations and data contained in this review of the literature. Upper images. Scanning electron microscope of human respiratory syncytial virus, variant blue, labeled with anti-RSV-F protein gold antibodies yellow, shedding from the surface of human lung epithelial cells. X-ray of a child with RSV bronchiolitis showing the typical bilateral perihilar fullness. Bottom images. Photomicrographic immunofluorescence detection of respiratory syncytial virus. Lumen of an obstructed bronchiole containing cellular debris and aggregates of sloughed epithelial cells. Respiratory syncytial virus infection usually produces widespread bronchiolitis and interstitial pneumonia, but may sometimes be associated with giant cells. This image shows a nonspecific interstitial pneumonia pattern with no giant cells present. Respiratory viruses are an epidemiological class of infections derived from direct fomite contact and or inhalation of viral secretions from coughs and sneezes that replicate in the respiratory tract, causing localized rather than generalized acute infections. A syncytium consists of a large cell-like structural combination of two or more cells. Respiratory syncytial virus results in inflammation and congestive syncytium formation in tissues. Respiratory syncytial viruses correspond to the pneumovirus genus, primarily causative of the usual lower respiratory tract diseases bronchiolitis and occasionally pneumonia, resulting in morbidity that can be particularly severe in infants, older adults, and the immunocompromised. Respiratory syncytial virus usually causes a cold-like mild upper respiratory infection, in contrast to the typically more substantial morbidity experienced by certain high-risk populations. This virus exhibits an incubation period of about 4 days, occurring within 2 to 8 days, as well as contagion for 3 to 8 days, with degrees of viral shed for a period of days or even weeks subsequent to the appearance of recovery. Disease is generally of less than 5 days duration. Reinfection is possible. Severe cases consistent with lower respiratory tract infection, resulting in mortality, are also exacerbated by advanced age and comorbidities such as asthma, chronic obstructive pulmonary disease, congestive heart failure, compromised immunity, diabetes mellitus, coronary artery disease, frailty, hematologic disorders, kidney disease, liver disease, pulmonary disease, and other underlying factors that increase respiratory syncytial virus attack rates and hospitalizations, particularly in the aforementioned high-risk populations. Respiratory syncytial virus occurs as distinct A and B antigenic groups based on the respective G protein structure subgroups. Symptoms include a cough, fatigue, fever, headache, pharyngitis, rhinorrhea, and wheezing. These symptoms tend not to be severe in older children and adults. Severely affected infants less than 6 months of age may exhibit temporary apneic breathing, bluish skin tint, severe wheezing, worsening cough, and measurably insufficient blood oxygenation. Rapid respiratory syncytial virus molecular tests are also diagnostic. Reverse polymerase chain reaction analysis is the preferred diagnostic test. Antigen, serology, and viral culture testing are less commonly used. Treatment consists of rest, maintenance of proper hydration, medication for fever, cough, congestion, and pain reduction, excluding aspirin for children. Respiratory syncytial virus monoclonal antibody administration, such as nirsevimab and palivizumab, and specific drugs such as the antiviral ribavirin currently provide for prophylactic and therapeutic patient care. Please study the immunization strategies for RSV section of this presentation for more detail. More severe symptom manifestations requires additional care, including hospitalization, administration of intravenous fluids, humidified oxygen, and occasionally mechanical ventilation. Structure of respiratory syncytial virus. Respiratory syncytial virus is capsulated pneumovirus of Paramyxoviridae family with three membrane proteins called small hydrophobic SH, attachment glycoprotein G, and fusion protein F. The F and G proteins induce protective, neutralizing antibody responses. An effective and timely immune response against protein F can prevent severe manifestations of the infection. Moreover, protein F is characterized by considerable interstrain conservation, making it an excellent target for potential vaccines and monoclonal antibodies. Protein G is important for the induction of protective antibodies and the modulation of host immunity. RSV is divided into A and B subtypes based on the protein G sequence. The A subtype appears to correlate with more severe infections. Both subtypes circulate simultaneously during the annual epidemic season, although typically one predominates each year. RSV structure and genome organization. A. RSV virion particle, and B. Single-stranded negative sense RNA genome consisting of 10 genes, NS1, NS2, N, P, M, SH, G, F, M2, and L. Schematic image of respiratory syncytial virus life cycle. Binding and entry of respiratory syncytial virus into the host cell. Firstly, RSV entry into airway epithelial cells through interaction with the G protein. Secondly, this attachment determines the binding of the RSV F protein to nucleolin, which leads to activation of cytoskeleton and actin filament reorganization of the RSV envelope to introduce its content into the cytoplasm of the host cell. RSV presents direct cytopathic activity, but signs and symptoms, which are virus-dependent, are also due to the local host inflammatory response, innate and adaptive immune responses created by its presence in airway epithelial cells. Classification of the upper respiratory tract infections, including respiratory syncytial virus, with the associated most relevant causative agents. Classification of lower respiratory tract infections, including respiratory syncytial virus, with the associated most relevant causative agents. The radiologic and tissue markers of bronchiolitis obliterans syndrome. Bronchiolitis obliterans syndrome consists of small airway lung disease characterized by bronchiolar smooth muscle hypertrophy, peribronchiolar inflammation and infiltrates, bronchiolar lumen mucus accumulation, inflammation, as well as terminal and distal bronchiolar fibrosis, with concentric narrowing of the lumen, as well as airflow obstruction and scarring with complete luminal occlusion, possible measurable by spirometry and visible upon imaging. Pathogenesis of RSV bronchiolitis. RSV first infects ciliated epithelial cells of the respiratory tract. Inflammatory cytokines and chemokines secreted by infected epithelial cells and macrophages attract inflammatory cells and cause inflammation and bronchoconstriction in the airway. The predominant inflammatory cells in the airway are neutrophils and alveolar macrophages. Dendritic cells are the main antigen-presenting cells that stimulate T lymphocyte function. Neutrophil survival is prolonged and interleukin-9 secretion promotes mucus production. CD4 positive T helper lymphocytes may be skewed to produce pro-inflammatory Th2 cytokines. The combination of epithelial cell sloughing, mucus plugging, and airway inflammation leads to the clinical presentation of acute bronchiolitis. Conceptual framework of respiratory syncytial virus infection, intensity, and impact. Immunization, both active and passive. The fusion F protein is the foundation of passive immunization against the respiratory syncytial virus. Immunization strategies for RSV. A. Recombinant vector-based vaccines. Use modified replication defector virus, induce a humoral and cellular response by delivering genes of RSV antigens. Effective against SARS-CoV-2, but associated with thromboembolic events. 3 vaccine candidates in clinical trials designed for pediatric and elderly populations. B. Nucleic acid-based vaccines based on introducing messenger RNA encoding RSV antigens into cells. Good safety and efficacy profiles against other viruses such as SARS-CoV-2. Phase 1 trial for an RSV messenger RNA vaccine in adults met primary safety and tolerability and secondary humoral and cell-mediated immunogenicity outcomes. C. Protein-based vaccines. Includes whole inactivated virus, particle, and subunit vaccines. Display various antigens to create an enhanced immunologic reaction. Current candidates are designed for older adults or mothers, young infant protection via passive transfer of antibodies. Many vaccines in different stages of clinical trials. D. Live attenuated vaccines. Mimic natural infections to generate a potent immune response while being attenuated for reduced virulence. Do not appear to cause vaccine-enhanced disease in infants and are considered safe. Compiled data from the 5 most promising vaccines showed 88% efficacy rate against medical attendances for acute lower respiratory illness. E. Monoclonal antibodies, passive immunization. This protein target is mostly conserved amongst strains. Examples include belivizumab, monthly intramuscular injections during RSV season, nirsevimab, single intramuscular injection before RSV season. New presentations coming soon. Like, share, subscribe, and ring the bell for notifications. Thanks for watching. Thank you to current and new subscribers.